Just give it another minute or two. Going. Actually, Mohammed's on vacation, is that right? He was
It's
on
up to
vacation. Is that right? I don't remember.
Yes.
Okay, I see Molly here, so we can get going. All righty. All right. This is a event recorder, actually what's called a loop recorder, for a patient who has hypertrophic cardiomyopathy and had intermittent syncope. Um, so the story was that this patient was actually delivering a lecture or a speech in front of his class in school, and the parents were invited. So this patient had what's called a loop recorder, which we don't see patients with loop recorders so much anymore, but a loop recorder is literally what it sounds like. It's had like 3 or 4 ECG stickers that were attached to a device about the size of your cell phone, and it's essentially recording the ECG continuously over a loop of about 2 to 3 minutes, and it would then re-record over the last 3 minutes. And so if you felt something in the prior 2 or 3 minutes, you would the patient would be instructed to press the button, and and then it would record the EKG in the actual memory of the device, and then you could actually download it over the telephone. This device still exists, but in the present era, we have somewhat more sophisticated ones. So what happened was this patient was standing in front of his class. He was giving a talk or a lecture. He felt faint. He passed out, and his father, who was in the room, literally ran to the front of the room and pressed the button on his loop recorder. He woke up, and this is the recording that we have. So, why don't we ask Dr. Marshall what she thinks is going on here, since she is a soon-to-be cardiomyopathy and heart failure transplant expert.
Good morning. Here it looks like at the beginning, this is all like in sequential time, correct? Like,
It is. It's a good
okay.
question. It is sequential from strip to strip to strip.
So at the beginning at the top left, it looks to me like it is a little artifactual, but I think it's sinus rhythm there, like that first couple. But then you see it overall change morphology, and from the top strip down to the bottom, it changes quite a lot.
So what do you think is going on over here in these at this point here?
You're seeing like distinct like changes in your ST segments.
Mm-hmm.
First it looks like in the top strip, it looks like depression, and then I guess it's still depression the other one, but it's overall changing morphology. So I think you're showing signs of ischemia.
Mm-hmm.
And then towards the bottom half, it just looks like I think polymorphic VT because it's looking like different morphology there.
Right. I mean, this is really basically this is VF already, right? The heart rate. It's how fast is this heart rate?
Yeah, by the bottom, yeah.
It's over 300 beats per minute.
Yeah.
But, I guess it's hard to tell exactly. So this is a really extraordinary strip, and it really highlights what we think happens to patients who have hypertrophic cardiomyopathy and arrest. So it's thought that there's a supply versus demand difference. And so you have a very thick heart. The theory is that you get subendocardial ischemia because the heart is so thick that the coronaries cannot provide adequate perfusion to the myocardium. And you start having ischemic changes followed, which causes VT, which is the same thing that happens when you're having a myocardial infarction. And so this was a really remarkable recording. So this had happened apparently 3 to 5 times. So, Molly, what would you do for this patient? So they wake up and they're okay, and actually just went on his day till they downloaded this.
And he's on medication or no?
I don't think he was on anything at this time.
So for him, I would ultimately probably put him on a beta blocker and then discuss ICD placement for him.
So when you say you discuss ICD placement, what do you mean by that?
As in schedule it and place it.
That is correct.
As in discuss their calendar.
Yes, exactly. So this is just about the highest risk of having another event as one could have, right? This is
Yeah.
VT or having actual episode of sudden arrest is in fact the number one biggest predictor in hypertrophic cardiomyopathy of having more events. So this is, as they say, do not pass go, do not collect $200, to use the Monopoly analogy, which probably many don't even know anymore. But this patient definitely warrants an ICD. The interesting thing is the patient was having intermittent syncope and was known to have hypertrophic cardiomyopathy, and yet still was, walking around like this. So we ended up putting an ICD in this patient, and but I think I'd say two things. So interestingly enough, he got shocked multiple times over the course of the next 15 years that I took care of him. He's now an adult, and it always occurred with exertion. And he was on. So you had asked about meds. What meds would you put him on, and why would you put him on meds, Molly?
I would put him on probably like Nadolol or some type of beta blocker.
Right. So, what's the evidence that those medications like beta blockers reduce the risk for this type of event?
I think that beta blockers are the only one that's been shown to have any reduction in those events, but no other
So,
medications
so I
have.
think you're conflating long QT syndrome with it.
Oh, you're right. I am. So so there's not.
Yeah, so long
Yeah.
QT syndrome, you're absolutely right. In long QT,
Yeah.
beta blockers are the only agent that have been definitively shown to reduce the risk for sudden cardiac death, other than things like ICDs and stuff like that. But in terms of medical therapy, although we're hopeful that's going to change over time. But in hypertrophic cardiomyopathy, there actually is no evidence that beta blockers reduce the risk of sudden cardiac death. Now, it might be that it does, but it does it to a smaller degree. And there are other reasons we put patients with hypertrophic cardiomyopathy on beta blockers. So I'm not disagreeing with the decision to do that. One of my older colleagues who I used to work with, Dr. Hordoff, was confident that, or felt strongly that they did probably reduce the risk of sudden death, but that the effect was so small that it couldn't be easily measured and it was not reliable or strong enough. So we would never hang our hats on a beta blocker in somebody with hypertrophic cardiomyopathy. So anyways, I think this is, the other point about this strip, which I think is very important, is that despite this very dangerous and obviously life-threatening arrhythmia that we're seeing at the bottom of the strip, rate over, it's really closer to 300 beats per minute, the tachycardia terminated on its own. And it actually had terminated multiple times on its own before he even got medical attention or had a defibrillator. And so this highlights also one of the problems in the literature of hypertrophic cardiomyopathy. Many studies that have been done, and I'm an author on one or two multi-center studies like this, essentially look at the number of ICD shocks and say, and essentially say that that is an episode of sudden cardiac arrest, when in fact, the episode self-terminated. So having an episode of VF or even needing a shock is not definitively equal to the risk of sudden death. And so and many of the studies that look at risk factors for sudden cardiac death are based on ICD recordings or even ICD shocks. But I think this case, unfortunately, I lost the rest of the strip, but it terminated on its own, literally like on the next strip. And again, one would never hang your hat on it, but it might inform how you're going to program a defibrillator in a patient like this. You might, for example, if you feel that this patient has a history of self-termination of their dangerous arrhythmias like this, you might make the detection zone longer so that patient has to be in it for a longer period of time. And you might make the redetect. So defibrillators will detect the arrhythmia, so you can tell the device, I want to wait 3 seconds, I want to see 6 seconds, whatever the case may be. Then it has to charge. And then there is usually a redetect zone for at least 1 second. You could make that longer also. And then it would deliver a shock. So in a patient like this, we might make the detection zone longer. And in fact, that's what I did. And he did have a number of appropriate shocks. And in every case, he would find himself on the ground and not 100% certain what had happened, but he was fine. And so, anyways, the point I'm trying to make is we should not always assume that just because you have something so horrible that you were actually going to die from it. Obviously, this is profoundly dangerous. Most of the time, people who have this arrhythmia are going to die from it without a defibrillator. But it's not a guarantee. Thankfully, there are people who survive these arrhythmias and spontaneously terminate. Any questions
The,
about this? Yeah.
the redetect is just that the device is making sure you're in the rhythm after the charging period. Is that?
That's exactly right.
Okay.
Yes. Yeah. Some devices, I believe it's programmable, others it's not. The other thing is that different companies do it differently. So for example, Medtronic, what you do is you tell it how many beats out of how many beats. So you can say if 8 out of 12 beats are over 200 beats per minute, start charging. Or you can say if 16 out of 20 beats are out, or if 32 out of 40 beats are. So what happens when you set that type of zone is that it is essentially continuously scanning let's say a 40 beat range of beats and is determining how many of them are falling into that zone. So it's really remarkable, the technology of an ICD that is constantly and continuously calculating all of these intervals in order to see if it meets the criteria that's programmed. And this is the reason why defibrillators, don't last forever, despite the fact that many of our patients never get shocked. Doing all of this sensing work is a very low battery drain, but it's not a zero battery drain. And so after, most ICDs in 2024 last about 10 years, a little longer, a little less. And that's markedly better than in the past. When I started my career, I think it'd be fair to say most of them were in the range of about 6 years. So they're much better than they used to be. There are smaller ICDs. Some of you may have seen either me or Barry put in the so-called mini device that's made by Boston Scientific, which we sometimes use in smaller patients. And the device is very effective, similar efficacy to the larger device, but it has a smaller battery. And that device is estimated, I think, to have about 6 to 7 years of longevity. Although recently, a patient of mine is having his replaced at 12 years after implantation because he never received a shock. So any other questions about this? So this is a very rare tracing I thought I'd share with you today. Okay. This is a 12-year-old fenestrated Fontan patient who is undergoing a cath for closure of the fenestration with an Amplatzer device, and they had this rhythm disturbance. So why don't we ask Dr. Vlad what he thinks is going on. So just so everyone is on the same page, we have 12-lead electrocardiogram going from top to bottom of the screen, and we have one catheter in the high right atrium. And this is presumably an atrial electrogram that we're looking at.
Good morning, Dr. Paz.
The
first thing that stands out to me is that in the high rate atrial catheter, it looks like there's a P before the first QRS, not before the second QRS, and then there's a P before the third, but it's a different interval than the initial one was. So to me, it looks like this could be a heart block, type 2, second degree heart block type 1, where the PR gets progressively longer as it looks like the QRS complexes are at a fixed interval and there's no missed beats.
Yeah, I think this is some kind of heart block of some sort, right? Now, why do you say heart block and not just like, I don't know, let's say atrial flutter? Why isn't it atrial flutter? Or could it be atrial flutter?
I think my brain thinks of atrial flutter as with the typical like, flutter waves, and it looks like there's many isoelectric regions between QRSs. So
Okay, that's true for classical atrial flutter. You're absolutely right. But for intraatrial reentrant tachycardia, which is the fancier way of describing flutter in people who have incisional atrial flutter from scars, it may not look that way on the electrocardiogram. What do you think about the atrial rate for an atrial flutter? What is the atrial rate in this tracing? Sorry, it's not the greatest tracing.
assuming there's no buried P waves, I would say
Well, do you think there are buried P waves? You have an HRA catheter with
no,
massive electric reps. So
I don't.
yeah, good. So what do you think the rate is?
About 50.
Wow.
Oh, I'm sorry. This is 100 millimeters per second strip.
Is it 100? No, I think this is 12 lead. No, it is 100, right?
So I got 6.
So the actual truth is, this is atrial flutter. It's just, it looks slower because the paper speed is so much faster,
Yeah.
right? And you're right, though. There is some kind of heart block related to it, but it might just be related to the speed of the atrial flutter, right? It's actually, we're going 4 times faster on the paper speed. So you can just imagine what the atrial rate is based on that. So,
200.
so what would you do if you were in the middle of this case and this happened?
Could you pace over
Yeah,
the rate
you could
since
pace.
you're in the high rate atrium?
Right, you could put a catheter in the right atrium, use this HRA catheter, and pace terminate the tachycardia. Any other options? Let's say the pacemaker is missing and they don't know where it is in the room. That would be by far the most elegant way to terminate this tachycardia.
And hopefully,
Would
Sorry,
you
I thought I heard Katoki's voice in the background there.
Yeah, I'm not accepting her answer yet.
Okay.
Could you cardiovert the patient if you're in the
Yeah,
cath lab, you have your
sure.
pads on?
Sure, you could cardiovert this patient. I mean, presumably the procedure is being done under general anesthesia. Although this could be done without general anesthesia, but as you know, in 12-year-old, we would normally use general anesthesia for this. Yeah, you could cardiovert the patient, or you could just pace terminate the tachycardia. That's in fact what happened. I believe we pace terminated this, and this was many years ago now, and then proceeded to close the atrial defect, the fenestration. Okay. So you were right. It is some kind of a block, but it's related to the speed of the atrial arrhythmia, not so much the AV node. Okay. All right. This is a tracing from a 14-year-old with a Fontan and PLE with poor ventricular function, a history of intraatrial reentrant tachycardia, who's admitted to the hospital, previously known to have first-degree AV block, now has increased fatigue and 1 episode of syncope. And this patient is on a very nice cocktail here of Lasix twice a day, digoxin twice a day, enalapril twice a day, aldactone, and is on amiodarone at a nice dose. So why don't we ask Dr. Kalis what she thinks is going on here?
All right. Good morning, Dr. Pass.
Good morning, Dr. Kalis.
All right. So looking at the strip, so looking at the rhythm strip below, it looks like we have the first beat that I'm seeing fully. I see a P wave, then a QRS, and then shortly, kind of right at the end of the T wave, I see another P wave that does not look to be conducted,
Mm,
or
and
it's with a very long PR interval. But
mhm.
so some sort of heart block there. And then the next P wave is delayed, kind of a longer P to P interval than the last. And it looks like there's another long PR interval there.
Mhm.
So I would say this is at least second degree heart block.
Mhm. Do you think it's Mobitz I or Mobitz II?
Let's see. I would call this, I mean, it definitely looks like the PR is prolonging, and then we do have a dropped one later. So I'm going to call it Mobitz I.
Yeah, I agree with that. I think this is an extreme example of Mobitz I. And patient had syncope. Of course, we're not going to know what the cause of that syncope is, but it could be from a pause. So, what would you do for this patient? So now the patient had syncope, so they get admitted, and they're seeing this Mobitz I, pretty slow heart rate. Patient was previously known to have first-degree heart block, but now has Mobitz I block, with a very, kind of mediocre AV node. Any thoughts on why this might be? Based on the history that I've described for you, the medications, et cetera, anything you would, how would you approach this, do you think?
Um, I guess in this patient, it could just be consequence of their heart disease progressing. It's poor, it looks like they have poor ventricular function and has a history of arrhythmias as well.
Right, but the arrhythmias that we are hearing is first-degree heart block and intraatrial flood, or intraatrial reentrant tachycardia. But now we're seeing Wenckebach. So this is different, right? Than does dysfunction, and I mean, this is clearly a bad Fontan, right? It has PLE,
Yeah,
has poor ventricular function, but does that cause you to have heart block?
not usually.
No, it doesn't. I mean, it's kind of like on the one hand, you could say, wow, this is obviously a bad Fontan, so everything must be bad with Fontan. But the conduction, wasn't great. We're told that there was first degree heart block chronically, but as the Fontan gets worse, it doesn't usually get worse, at least not in a short period of time. They could, but not usually. Any other like what about our therapy could possibly be causing this? So now you're in the ER, you hear a story of syncope, you see this ECG, you pull up the old ECG and Epic, and you see that she was conducting with a PR of 220, 1-to-1. You look back, there's a couple of tracings for over the last 2 or 3 years that all show that. So now you're in the ER, and the ER is like, well, what do you want to do, Dr. Kalis? And you say, well, I definitely want to admit them because I want to keep an eye on this. But what is there anything you might do in the emergency room? Any blood work? Anything at all?
I guess we could check our drugs to see like at a dig level.
Yeah, you definitely would want to get a dig level. This is not an insignificant dose of digoxin for somebody who's on amiodarone. What happens to digoxin with amiodarone?
I think it can increase the dig level.
Yeah, this is I want everybody in this room to remember this. Amiodarone raises digoxin levels. That's a very, very, very important point that is almost guaranteed to be on your board. So everybody in this call just got one question right on their boards. That's exactly right, Maya. It raises your digoxin level, and traditionally, what we recommend is lowering the digoxin dose to a half of the usual dose. So a typical adult might be on 0.25 milligrams, but to be on 0.125 BID, that's a pretty stiff dose for somebody who's on amio. So you would certainly want to check your dig level in order to see if that was possibly a culprit here. Anything else could be causing this, or any other testing that you might want to do? What do you think about amio for IRT anyways? Like, do you agree with the management that this doctor was using on her, giving amiodarone every day for a Fontan patient with IART?
I don't normally think of amio as a treatment for IART.
So a lot of times we'll use it temporarily. It turns out that there's actually a fair bit of evidence suggesting that amiodarone is actually not even any better than digoxin for the prevention of IART. The reason that there's been a lot of efforts over the last 20 years to work on IART ablation is because of the generally lousy track record of drugs for the treatment of IART. Recently, some of you may have been involved in a case where we cardioverted this guy who is a Fontan in IART, and I made the observation that I usually give everybody a free cardioversion, meaning I don't do anything different for them. And the reason is because the only really different thing that makes sense is to do an ablation, because most of us will try a drug, like we might add a beta blocker, or we might start sotalol, or even flecainide, and sometimes even amiodarone. But it turns out that in the studies that have looked at this, almost all of these drugs are not especially helpful. Now, there are rare patients in whom it does make a difference, so I'm not saying it's wrong to try, but generally speaking, amiodarone, or really any agent, is almost no better than placebo for the prevention of it. So, you're getting your dig level, it's pending. Anything else you might do in this patient?
I guess I'd also check electrolytes.
Okay, the old check the electrolytes. We'll give you full credit for that, even though I've yet to find the patient in whom that showed anything, but okay, they're normal. What would you do with the amio?
I would probably hold the amio until
Yeah,
hold
we'd certainly hold the
both of them.
Right, yeah, I think so. We would hold both of those agents in order to see if that is having any impact. And so, you'd have to figure out whether or not the amio and digoxin, whether each or both of those are having an impact. And, it might not be unreasonable. So you'd maybe watch this patient for a little while, but one option might be to stop these agents and do an ablation, paradoxically, and see if we can get rid of the IART so that we can come off of at least the amiodarone. Because it might be that your therapy, the amiodarone and the digoxin, may be the cause of this. And the one thing I really hate in arrhythmia management is placing a pacemaker to treat the side effects of your medical therapy, if there is an alternative. And so the alternative here would be to try to ablate this. Now, I say this with the courage of the non-combatant. It's hard to ablate IART in Fontan patients for many different reasons, and they're very long and arduous cases. But if you're successful, you can make a massive impact on a Fontan patient's life. So in this case, we would be worried that there is an iatrogenic component of this, which is explaining the Mobitz I block that you're seeing there. And you would, now, if you were to have done an ablation, if you stop the medications and you still see this, then this patient is probably going to need a pacemaker. And how would you put this pacemaker in? Would you do a transvenous system in this young lady?
No, I think I'd do an epicardial pacemaker.
Right. You can't really do a transvenous system. Why is that? Single or dual chamber?
Well, if you needed to put a pacemaker, I guess you would want to do a dual chamber.
Absolutely, yes.
But I guess it would be hard. You couldn't really access the atrium and the ventricle given the anatomy.
You're right. So increasingly, some electrophysiologists are putting in transvenous atrial leads in Fontan patients sometimes, particularly in older style Fontans, whether it be lateral tunnel or so-called atrial pulmonary anastomosis, where you can actually access the atrium. Some will do that, although traditionally we have not recommended that because pacemaker leads develop thrombi on them in everyone, including people with two ventricles. But the reason it's never clinically a problem is because there's no holes in the heart, and so you might have some microemboli to the pulmonary arteries in people who you put a transvenous lead in, but it usually is not clinically important. But in a Fontan, we would be worried. So if you put a transvenous atrial lead only in a Fontan patient, you would need to anticoagulate that patient. And there is concern that even with anticoagulation, you will not prevent the possibility of a paradoxical embolism. Remember that most older Fontans have a lot of veno-venous collaterals, so it is not without risk to place a transvenous atrial lead, but some would say that it's so hard and challenging to put an epicardial atrial lead that they would go transvenous in this setting. But you're 100% right. You can't place a V lead in this patient because transvenously because there is no connection between the atrium and the ventricle. And even if there were, even if you did a transbaffle puncture, you would then be putting a lead, which has a very high thrombus risk, in the systemic ventricle. And we know from lots and lots of case reports and data in the distant past that that is very, very highly associated with risk for stroke. So we would never ever put a transvenous lead in the systemic ventricle of any patient, but especially in a Fontan patient with bad function who already is at risk for thrombi. So this would almost certainly have to be an epicardial system, which is a very big deal, which is why one would potentially go through the trouble of doing an ablation for this IART and seeing if you could come off all of these potentially toxic medications, because that would still be less of an invasion than doing a thoracotomy or a sternotomy and putting in a dual chamber pacemaker. Many of you have probably seen that we drag our feet very substantially in single ventricle patients in regards to pacing. And that is because of the big deal that it is. It's not open heart surgery, but it's a very big deal to put an epicardial system in a Fontan patient. And and the other thing I would say is in regards to the question of single versus dual chamber, single chamber pacing in Fontans is generally associated with very bad outcomes. There have been studies that have shown that if you have any kind of heart block and you're V-paced without AV synchrony in a Fontan, it's associated with much worse outcomes, less longevity of life, more heart failure, etc. So if you are going to put a pacing wire on a Fontan patient, as you suggested, Maya, it really needs to be a dual chamber system, not a single chamber system. It's really, we've talked in the past that the big benefit of dual chamber pacing is that you have AV synchrony. And for people who have normal function, AV synchrony is not that important. It only adds maybe 5 or 10% to your cardiac output. But in people who are in low cardiac output with bad function, the loss of AV synchrony can be literally a 20 to 40% reduction in cardiac output. So you really, really need AV synchrony in patients who have heart failure or bad function. So this would, if this ended up being a pacemaker, this patient would need a dual chamber device. But the hope would be of all these things, right? The thing we would most hope is the patient is digitoxic, because if they were digitoxic, that would be an easy fix. Just stop the digoxin, everything should improve. The other thing is it could be hypothyroidism related to the amiodarone. So one would definitely want to send thyroid function studies. That would also be a nice problem because that could also potentially resolve with stopping of the amio. Although, Maya, what's the half-life of amiodarone?
It's quite long. I'm
What's
trying to
it?
remember exactly. It's like on the span of like days to even weeks, I think.
It's actually about 6 weeks.
Yeah.
So, and that's the reason, by the way, why when we load people, we give very high doses, right? We give sometimes 10 per kilo or 20 per kilo for a number of days because we're accepting the fact that the half-life of enteral amiodarone is very, very, very long. And so even if you decided in the emergency room to stop the amiodarone, now if the amio had been started 5 days ago, it's different. But if this patient had been chronically on amio for 6 months or 12 months, then stopping it might be the right thing to do, but you might not see the impact of stopping the amio for 3 months. So, you always keep that in mind when we're talking about amiodarone. It is, I believe, the agent that is known to have the longest half-life of pretty much any medication that exists. A very, very long half-life, about 6 weeks for amiodarone. All right, any questions about this? I think with that, we'll stop for today. Hope everybody has a wonderful day. See you in Sinai in a short while. Thanks, everybody.
Thank you.
Thank you.
Bye.